Welcome to The Explainer. I'm stepping into my role today as an expert urological surgeon and genitourinary trauma consultant to bring you something absolutely critical. Look, we're preparing for clinical mastery on the wards here. Because when that pager goes off at 3 a.m. and a patient's life or literally their limb or organ is on the line, you just don't have time to thumb through a textbook. You need hyperdense, rapid-fire clinical pathways hardwired directly into your brain. So today, we're initiating the 280+ execution protocol for genitourinary emergencies. We're going to strip away all the fluff and focus purely on the high-yield, life-saving surgical algorithms.
Okay, let's dive into this. Here's our tactical game plan. We'll kick things off with our protocol initiation, and then move through 3 core modules: scrotal disruption, obstructive uropathy, and genitourinary trauma. Finally, we'll lock the whole thing in with a mandatory validation drill.
Protocol initiation, the first principle framework.
To perform like an elite surgeon, you've absolutely got to actively filter clinical noise to isolate first principle pathology. Rote memorization? It completely fails under pressure. Period. When a patient is crashing in front of you, grounding your decisions in core anatomy and physics is the only thing that will save them. And this requires signal-to-noise filtering. Now, the noise is all that distracting history, the vague timeline or that minor bump they had 2 days ago. But the signal is the pathognomonic clinical sign staring you right in the face. If you can learn to separate the two, you'll never get tripped up on the wards.
Module 1. Scrotal Disruption. The Ischemic versus Inflammatory Fork.
Picture this. You're called down to the emergency department for a young male with classic acute scrotal pain. Right away, your mind has to visualize this first principle concept. Are you dealing with ischemic arterial occlusion, where the spermatic cord is physically, mechanically twisting and completely cutting off the blood supply? Or are you looking at inflammatory hyperemia? That's a bacterial infection like chlamydia or gonorrhea, which actually causes a massive increase in blood flow to the area. Distinguishing between these two physical states is the entire key to this disruption fork. One requires antibiotics, but the other requires you to operate immediately.
Welcome to the judge's bench. Now, what's really interesting about this setup is how perfectly it lets you rapidly visually scan for your signals. In testicular torsion, the pathophysiology is spermatic cord twisting, right? The ultimate signal here is a pathognomonic absence of the cremasteric reflex. Plus, you'll see a negative Pren sign, meaning if you elevate the scrotum, it doesn't give them any pain relief. Conversely, acute epididymitis is an ascending bacterial infection, so the cremasteric reflex is beautifully preserved, the Pren sign is positive, and their urinalysis is going to light up with leukocytes and nitrites.
If you go ahead and order a transverse Doppler ultrasound, this is exactly what you're looking for. Notice the right side here compared to the left? The Doppler absolutely proves asymmetric swelling and a severely decreased blood flow to that right testicle. This right here is your visual proof of an ischemic testis. And when you see this, man, the clock is ticking. You've got less than 6 hours to attempt manual detorsion or get them into immediate surgery to salvage that tissue before it infarcts completely.
Time for our first pathology variance box. I need you to lock this into your brain permanently. An absent cremasteric reflex in the setting of acute scrotal pain is a surgical emergency until proven otherwise. Do not, I repeat, do not, get distracted by a history of sports injuries or some vague timeline. Absent reflex equals torsion. End of story. Execute the surgical protocol.
Module 2. Obstructive Uropathy. Hydrostatic Pressure Gradients.
All right, we're leaving the ischemic pathways and entering the realm of fluid dynamics and physics. The first principle concept here is hydrostatic retrograde pressure filtration failure. So, think of the kidney as this incredibly high-pressure filtration pump. When a stone impacts the ureter and blocks up the plumbing, well, that urine has nowhere to go. A backward pressure gradient starts to build up, and it literally fights against the kidney's own forward flow. This physically collapses the kidney's ability to filter blood.
Let's move along and see how this builds across our chronology map. Step 1, nephrolithiasis, so a kidney stone, impacts usually way down at the ureterovesical junction. Step 2, we get this massive retrograde accumulation of urine. Step 3, hydrostatic pressure aggressively spikes backward, all the way into Bowman space inside the nephrons. And finally, step 4, the glomerular filtration rate just completely collapses, and acute hydronephrosis develops. Actually, it's basically a retrograde wave of destruction.
And this brilliantly illustrates the endgame of all that pressure. Over on the right, you're seeing a healthy, normal kidney ultrasound. Nice, thick, robust cortex. But on the left, that's severe hydronephrosis. Look at that massive, dark dilation of the renal pelvis and calyces. All that black space is trapped fluid under immense pressure and has physically crushed and thinned out the overlying renal cortex. No way around it, it's a structural disaster.
Now, let's map that pathology to our severity invasiveness scale. If your patient is stable, meaning they've got normal creatinine and a stone under 5 millimeters, they can likely just pass it spontaneously. Discharge them with oral hydration and an alpha blocker like tamsulosin. If they're emergent, say the stone is over 10 millimeters or they've got bilateral obstruction, admit them for IV fluids and schedule a ureteroscopy or lithotripsy. But look closely at that bottom row. If they are critical, presenting with a fever and hypotension, that is an infected stone. They require immediate, emergent decompression using a percutaneous nephrostomy tube or ureteral stent.
Which brings us to our next pathology variance box. I really cannot stress this enough. An obstructing stone coupled with a fever is a critical, life-threatening medical emergency. That trapped, infected urine is going to trigger catastrophic sepsis. If you do not rapidly decompress that system, your patient will die, for sure.
Module 3, Genitourinary Trauma, Bladder Wall Rupture Kinetics.
We are moving straight into the trauma bay now, where high-speed physics meets human tissue. The first principal concept that dictates your surgical decision-making here is intraperitoneal versus extraperitoneal fluid extravasation. The anatomical location of the bladder tear completely determines whether toxic urine is leaking freely into the sterile abdominal cavity or if it's safely confined down in the retropubic space of the pelvis.
Let's step back up to the judge's bench to contrast these two traumatic presentations. An intraperitoneal rupture happens at the bladder dome, usually from blunt force trauma, like a seatbelt just compressing a really full bladder. The contrast dye will wildly outline the bowel loops, and this mandates immediate surgical exploration and repair. On the other hand, an extraperitoneal rupture occurs at the bladder base. This is typically sheared by bone spicules from a pelvic ring fracture. Here, the contrast stays confined to the pelvis, and believe it or not, you can actually manage this conservatively with just a Foley catheter to drain it.
But hold up. Before you even touch a Foley catheter in a trauma patient, you must check your signals. So the absolute crucial point is this. Blindly forcing a catheter into a severed urethra will turn a partial tear into a catastrophic, permanent destruction of the patient's anatomy. Look for your signals first. Blood at the urethra meatus, a high-riding prostate on the rectal exam, or a scrotal hematoma. If you see any of those, stop. Just stop. Perform a retrograde urethrogram first so you can visualize the continuity of the urethra.
Here is your trauma pathology variance box. If you shoot your cystogram and that contrast dye begins to outline the loops of the small bowel, you have an intraperitoneal rupture. That right there is the ultimate radiographic trigger. You are wheeling that patient straight to the OR for an exploratory laparotomy. No questions asked.
Mandatory validation drill, rapid clinical retention.
All right, we've covered the first principles. It's time to simulate rounding on the wards and filter the signal from the noise. I'm going to give you 2 rapid-fire vignettes. Vignette 1. A 14-year-old male is awakened by sudden severe right testicular pain. He experienced a minor bump to the groin during a soccer game 2 days ago. On exam, the right testis is high-riding with a horizontal lie. Stroking the medial right thigh elicits no movement of the testis. I want you to actively filter this. What is the single next step?
Okay, let's break it down together. The minor bump during a soccer game 2 days ago? That is pure clinical noise meant to distract you. Throw it out. The signal here is that stroking the medial thigh elicits 0 movement. That's an absent cremasteric reflex. The chronology proves spontaneous spermatic cord twisting leading to arterial occlusion. So the only correct next step is immediate surgical exploration for testicular torsion. Vignette 2. A 34-year-old male is brought to the ED following a high-speed motor vehicle collision. He has a pelvic fracture and gross hematuria. A retrograde cystogram demonstrates contrast extravasating into the peritoneal cavity, outlining the loops of the small bowel. I want you to visualize that cystogram signature right now in your mind. What is the most likely diagnosis and management?
The chronology shows blunt force trauma to a full bladder, resulting in a dome rupture. The diagnostic signature, contrast outlining the small bowel loops, is the absolute giveaway. The diagnosis is an intraperitoneal bladder rupture, and the management is immediate surgical exploration and operative repair. You've now mastered the 280-plus genitourinary execution protocol. So my final question to you is this. When the trauma bay descends into absolute chaos, will you fall for the clinical noise, or will you execute the protocol? Keep learning, stay focused, and I'll see you on the next explainer.